I think I'm the second to last talk that separates you from the deep dish option you're going to choose for this evening, so we're going to try and go through this. There is some duplication that I heard earlier this afternoon about some of the stuff we're going to go through, so I may go through that a little bit faster, but please ask questions or stop me. So we're going to talk about cardiac involvement in systemic illness. Let's start with a case. So here's a 60-year-old guy, comes in with a tanned appearance. You see here, he's sick for the last couple of weeks. His chest x-ray shown there. He's got elevated liver function tests and pulmonary congestion on exam. What is the most likely diagnosis based on a limited stem? Cardiac involvement of hemochromatosis, amyloidosis, sarcoidosis, or hypereosinophilic syndrome. Okay. Good. That is what I was looking for, was cardiac hemochromatosis. So it is multi-organ involvement disease. It's related to deposition of iron and all of the things you see there. It is directly toxic to the myocardium, so it often presents as a dilated cardiomyopathy. The diagnosis is critical, so you should really be searching for this with most of the DCMs that arrive. It is reversible if treated in most cases, not all. I say it's more predominant in males, but the truth is it's actually diagnosed probably earlier in men than in women. Some people have proposed that it may be related to menses, but it's an autosomal recessive disease and related to HFE gene. And if you look at some of the data on this, which I recently reviewed, it can be up to about 5 out of every 1,000 folks. So it's really common, and we should be thinking about it more and more. Diagnosis usually is with transferrin saturation because ferritin levels are elevated, but it's a non-specific finding, as you well know. The guidelines for liver disease say 45% or higher. For women, for cardiovascular diagnosis, they usually say 50% or higher, 60% for men. So I think if you keep 50% for transferrin saturation, that will be sufficient to get you to the right answer. Echo is usually the first study you use to evaluate it. Dilated LV, normal wall thickness, it's usually global LV dysfunction. It can be associated with arrhythmias, both atrial and ventricular. There can be conduction disease, so many times they will present with some sort of sinus node dysfunction. Diagnosis can be any of these. I already mentioned transferrin saturation, biopsy of the liver, cardiac biopsy, but you heard about this earlier, I think yesterday, where MRI has really become an important way to evaluate iron deposition. You can see it on regular images even without contrast. These are specific T2 star weighted images where the diagnosis is less than 20 milliseconds. The lower that number, the more severe it is, and actually the less likely it is to reverse with chelation therapy. So I mention this because probably you know this as bronze diabetes, right? Congestive heart failure, diabetes, bronze type spin and hepatic failure. That's a real case. I changed the picture of the patient, and actually some of you in your book, I wonder if it may have said the patient presented with cardiac arrest. He actually ended up having cardiac arrest. He's real, but when I showed him the question, when I told him I would present him in Chicago, he asked if I would not have him die during this weekend. So I took that part out. So he just syncopized. Next case, 42-year-old female, marked fatigue and dyspnea, decreased exercise capacity, slow and insidious process. She describes hot flushes, edema, and abdominal distress. What is the next step in her evaluation? Nothing more, right? How about that? My wife liked that. Echocardiogram, ID consultation, or MRI of the heart. Oh, there's one person who had the guts to do that. 1%. Okay. Yeah, we want to see you in the back. So what I was looking for was echocardiogram. So these are slow-growing tumors, carcinoid tumors. They are neuroendocrine tumors in the gut. They produce vasoactive substances you see here, bradykinin, histamine, serotonin, all of those. Now, I highlight 5-HIAA because that is the excreted metabolite of serotonin. That's how you're going to make the diagnosis in many cases by ordering a 24-hour urine with 5-HIAA. It is the metabolite primarily of serotonin. Most of these vasoactive substances are degraded in the liver and then again in the lungs. So most of the carcinoid syndrome, which is what you'll see here, comes from metastatic disease to the liver. So it's got to get into the liver and then causes the flushing and the wheezing that we think is maybe related to histamine primarily, some of the diarrhea related to somatostatin. Now, the only caveat to that is that if you have an ovarian tumor, there's a different drainage system for that, so you can get around that. It doesn't have to be a met to the liver if it's just in the ovaries. I doubt that will be there on the exam, but it is something for you to note that is one caveat to liver mets. But what you're worried about is carcinoid valvular involvement, right? It can cause myocardial thickening, but most of the time what they're going to show you is a case that looks like this, where the valves here are going to be thickened and rigid and fixed in place. Sometimes they actually curl backwards, and they've been described as a shepherd's crook. There's wide open severe TR in exam. By all features, it's going to be wide open. The giant V wave will be present. Now, don't forget it can affect the pulmonary valve as well. So not just the tricuspid valve, but the pulmonary valve can be involved, thickened, often difficult to visualize because they can be completely destroyed. But when you see a signal that looks like this, rapid deceleration, they may show you that. They may ask you if you want to investigate any of the other valves. TEE, MRI might be your next step. RV dysfunction is common when you see this disease. Myocardial mets can occur, 5%. Remember, it's fairly rare disease, so only 5% of the rare disease, so that's fairly uncommon. Left-sided valvular heart disease can happen with some caveats. So you have to have a PFO, right? It's got to be a shunt across the PFO. And there should be, or it could be a bronchial tumor. In theory, they may ask you that. Or overwhelming carcinoid syndrome. If it's completely untreated and there's tons of all of these vasoactive substances circulating, you may get left heart involvement. So, if they give you a case, florid right-sided heart failure, they're going to give you probably some skin finding, diarrhea, flushing. They may ask you how to diagnose it. Octria scan is the answer for that. So somatostatin agonists or tumor embolization will be for therapy. They will make the patient feel better. They may ask you about valve replacement. So these days, valve replacement is indicated by most centers for at least the tricuspid valve. Some controversy as to whether or not you would do the tricuspid valve and the pulmonary valve. Limited data, most of it from the Mayo Clinic, indicates it improves longevity, reduces symptoms, people feel better. So valve replacement may be on the board and may ask you that. Again, right-sided valves are the dominant feature, rarely left-sided. Okay, 27-year-old with chest pain. He's referred to me for apical hypertrophic cardiomyopathy. This is another real case. Some contrast. Good. Which of the following is next will be most helpful? SPEP, ferritin, CBC, MRI heart for assessment of scar burden, or a urine 5-HIAA. Okay, the majority got that right, looking for a CBC. So what I'm trying to show you is hypereosinophilic syndrome, right? Sometimes referred to as Loeffler's. I think the literature on this is really complicated. Initially described by Loeffler, pulmonary disease, and now it's sort of expanded. Really hard for me to wrap my hands around this to try and sort it out. But the short answer is, it's an overproduction of 15, you're going to look for peripheral eosinophilia. Over 1,500 is the diagnostic criteria, and it's usually associated with one of the three subtypes. First is malignancy, sometimes referred to as primary hypereosinophilic syndrome. Second is secondary or parasitic infections, can be associated with this. or some sort of syndrome, Churg-Strauss syndrome being the one that typically comes to mind, and of course, idiopathic. So if you see it, they're going to describe something like that. One of my fellows who was actually in this room sent me a case overnight and said this is a new diagnosis of apical hypertrophic cardiomyopathy. Not this case. Another one, it was 4 o'clock in the morning. It wasn't as funny then as it was the next day when we made the diagnosis. So they can present a variety of ways, much of which they're asymptomatic. You have no idea that they have that restrictive cardiomyopathy. But when it happens, they often will present as myocarditis as the first phase, then leading to that thrombus formation and some myocardial thickening, and then long-term you can get fibrosis. And when you identify this by MRI, and we have a couple of these cases, the scar burden is everywhere. It's sort of a non-vascular distribution. It doesn't seem to fit anything. You have to track backwards to find the hypereosinophilic part. So it's restrictive physiology by echo. Most of the time, that's how you're going to make the diagnosis. The symptoms can be really anything from asymptomatic in the majority to any of the things you see there. An MRI may have a role in helping you distinguish. Where's my pointer? Can I have the pointer back? Helping you distinguish the thrombus there. Normal underlying thickening myocardium. I don't know what's happening, but I can't do it. And then by delayed enhancement imaging, you can see some of that scar tissue and burden all at the apex. So normal underlying thickening muscle with a thrombus that still is formed. Okay. Next case. 58-year-old female presents with dyspnea. 6 months history, exertional dyspnea, sweats, hair loss, anxiety. The findings you see here on physical exam, she's tachycardic, irregular. This is the rhythm strip, and her echo is on the right. You're right. Okay. Which of the following tests is the most appropriate? CT for pulmonary embolism, cardiac biopsy, labs including a thyroid, cardiac MRI to look for scar. Good, 96%. Good. So you already heard about this one, so thank goodness. We learned earlier today about hyperthyroidism. I'm going to go through it quickly because you already heard it. Tachycardic, increased cardiac output, increased blood pressure with a wide pulse pressure, often associated with atrial fibrillation and a higher risk of systemic embolism. You want to treat the underlying thyroid disease before you worry about the fib, right? It's a symptom, not the primary issue. You got to take care of the thyroidism first. It can make coronary disease worse for all the mechanisms you see here. And if you find tachycardia-induced cardiomyopathy, usually if you control the fib and get them in a rhythm, it fixes itself. Hypothyroidism being the reverse. Decreased contractility, decreased cardiac output, changes in peripheral vascular resistance you heard about. The one here to make sure you know about is pericardial effusions. Right, so pericardial effusion is certainly on the list for hypothyroidism. Okay, here's a 21-year-old with dyspnea. She presented, this is another real case, 3 out of 6 holosystolic murmur. She thought she was diagnosed with lupus prior to this, came to the hospital because she was nervous. She thinks she's pregnant now, and she's had 2 failed pregnancies. Came in with a transthoracic echo that showed valvular heart disease. Went on for TEE, which is shown here. Zoomed up view, and a little bit of color. Okay, what is the next step? No further testing. These are nodules of Aurantius. Initiate anticoagulation, ID consult, or an MRI of the heart. Are we going? No? You have to use hands? Is that what you said? Straws? Okay. So who thinks these are nodules of Aurantius? Okay, those are on the aortic valve, so that's not right. Initiate anticoagulation. Okay? Who wants to get an ID consult? It's always good to have more. Or an MRI of the heart. Okay, keeping Dr. Hunley in business. Okay, what I was looking for was anticoagulation. So hopefully what I'm showing you is Liebman-Sachs endocarditis. That's what this was, right? These were verrucous valvular lesions on the tips. I wonder if I can go back. I think I show them again. And they can be associated with any of the things you see here. So lupus is really what we were getting at. It can be a separate entity with just antiphospholipid antibody syndrome alone, and it can be associated with an underlying malignancy. So MR and AR are the most common associated with this disease. It is associated with recurrent fetal loss, specifically when it's associated with lupus. And you should consider this finding when you see any of the things here. Now, anticoagulation is a therapy of choice for managing this, at least initially, usually with low molecular weight or heparin, and then transitioning on. In this case, we treated her. They melted away. The valve disease went away. She's actually had 3 subsequent pregnancies since then and is doing very, very well. Okay, so lupus, actually, I wonder if I can... I'm going to start with this one. Chronic recurrent inflammatory disease, more common in women, causes inflammation of all of the entities you see here: skin, kidneys, blood, vessels, joint, skin. The typical malar rash, livedo-reticularis, is common. I'm going to go back. Go back again. Okay, so this is the echo that I showed you before. Again, it's a limited stem, so I couldn't argue with you if you wanted to do an ID consult to make sure that there's nothing else going on. But with that stem leading you down towards lupus, I was hoping you were going to lop onto that. Cardiac involvement is myocarditis, can occur, although rare. Coronary arteritis, and pericarditis is probably the most common way lupus presents for in terms of cardiac involvement, about 25 or 30%. So here's a 48-year-old, 6 to 8 months of progressive dyspnea, edema, fatigue, elevated JVP, all the things you might associate with the chest x-ray that you see here. So there's no question with this. I just wanted to make sure that we went through a differential for this chest x-ray, right? That egg calcification that's there. Hopefully you're thinking of radiation disease, right? That could be valvular heart disease, premature coronary disease, especially in the proximal LAD, restrictive disease, and of course a calcified pericardium. But it could also be related to other things like dermatomyositis, tuberculosis, and just idiopathic calcification. Some folks just have more calcium in their pericardium than others. So I just wanted to make sure we touched on that. These sorts of things are often shown on the board. We see a lot of Lyme disease. They will typically give you a good story with a rash that looks like that. We see a fair amount of it. Very, very, very few of them have the typical bullseye rash, or at least that they can remember in our experience. Cardiac involvement's about 10%, usually AV block. We had 2 a couple of weeks ago. Or Lyme carditis. Treating that usually melts away that heart block very, very easily. And these days, an MRI, and you've heard a lot about this, is another way to make the diagnosis if you're not sure for involvement of myocarditis. So this is a black blood T2 weighted image showing edema here, and then that patchy epicardial distribution here, very, very typical of myocarditis. Last case. Here's a 32-year-old who presents for assessment. She's otherwise healthy. She notes changes in her hands that look like this. Resolve spontaneously. Her hands and feet are the only parts involved. So she wants to know what you would like to do next. Are we doing hands or are we good?
Come on and back. Baby, you don't know me 'cause you're dead wrong. What doesn't kill you makes you stronger. Stand a little taller.
Okay, split down the middle. So I was trying to go for D, trying to show you that this is Raynaud's. So this is blanching, triggered by cold. We used to see this a lot in Minnesota when I was there. Seemed to be, what I read was more fingers than toes, and can be associated with other connective tissue diseases. But in this case, without any other sequelae, what I was looking for was Raynaud's. So I don't think the answer is important as much as the thought process to go through that it could be Raynaud's. I can't argue that it could be one or the other with the limited amount of information I provided you, but it's more the thought process of whether thinking about Raynaud's in something that looks like this with the typical blanching and cyanosis pattern. And then just a couple more slides. Here's a 17-year-old basketball player with a new heart murmur sent to you with this. Your echo shows the following. Here's the CAT scan. So I don't want to step on Dr. Eagle's toes, but I wasn't sure if you were going to go over this or not. I didn't see your slides until I got here. But this is Marfan syndrome. But there's more to it than that, right? Don't only think of Marfan syndrome. Whenever you see aortic disease, and just a reminder about the genetics that are associated with this. I had 3 genetic questions on the board that I took in April. 3 of them asked me specifically about the diseases you see here. So FBN1, I know he's going to go into depth criteria. I looked at your slides earlier today, so he's going to go into this in depth. Loeys-Dietz, vascular, Ehlers-Danlos, bicuspid valves we see a lot of controversy over whether or not the bicuspid valve with a little bit of aortic dilatation can still play sports. Some controversy over that, but there are the genetics associated with that. Osteogenesis imperfecta and ankylosing spondylitis should all be in your differential diagnosis when you see a dilated aorta. I have a genetic counselor in the clinic that I run that sees all these folks, so she helps me sort through the genetics of all this and reminds me, and she sometimes laughs at me a little when I try and say stuff about genetics, and she smiles and says, "You're mostly right." And then Kawasaki's disease. I don't think they're going to ask you about kids, but they may describe the disease, right? And I had this later on. They showed an image, but be familiar with at least the things that they may describe. She had several days, high fever as a child, described polymorphic rash, some oral mucosal changes, sometimes referred to as the strawberry tongue, some edema and desquamation of the hands, right? So they may describe that and then ask you what the sequelae are. You heard about some of this already, coronary artery aneurysms. There's some controversy, I think, over how you follow these. I only have one, and the only way I follow them is by CT or not at all, depending on what age they are. Most of the time, at least in the literature I've read, they don't do a whole lot after several years. They seem to be quite stable. And that's all I have. Good luck.